Thank you, Dr. Pro, for your nice presentation. We move on to the next speaker, Dr. Byron Gutt. He has been introduced already, but Dr. Gutt has a long interest in how culture influences illness experience and the expression of symptoms with a particular focus on psychopathology. The title of his presentation today is Worldwide Differences in Psychopathology and the Interpretation and Effects of Stress. Dr. Gutt.
So when Ami asked me to talk about cultural differences in psychopathology, I somehow didn't think exactly of this being in relationship to a session on pathophysiology of functional bowel disorders. And let me do the following. I'm going to tell you the talk I would give if I were to write it right now, and then I'll quickly go through my slides and show you show you some data and some information, and then use it also to talk back about the issues that this now brings to mind. So I think if I were to sit down right now and make up a set of PowerPoints focused on this question of the relationship between mental health issues, mental illness, and stress issues related to pathophysiology, some issues I know about and some issues I don't know about, I would certainly do the following. I would talk about acute somatization and what we know about acute somatization and how it leads to focus on the body and how culturally people focus on different parts of the body. I would, and I'll come back to this, talk about amplification that may occur in certain ways associated with catastrophic cognitions, etc. I would secondly talk about the difference, and this is something those of you who know the work of Arthur Kleinman would know. I would talk about the difference between chronic somatization and acute somatization, and talk about under what kinds of conditions somatization becomes chronic. I think we could think through the question of the differences between very specific somatization that focuses on one part of the body versus people with very general and multiple forms of somatization in which the gut is referred to, but in which wide variety of symptoms are talked about. I think there are issues of particular focus on pain in some settings and not so much in others. And I think, given the last talk, I would also talk in somewhat more detail about what do we know about eating disorders across cultures, and how eating disorders, for instance, there is some really fascinating information from areas before television arrived, where when television arrived, it led to very dramatic change in eating disorders, and a question of whether there's interaction between eating disorders and functional bowel problems. As we've just heard, one would have to talk about this on the one hand in terms of dramatically different socioeconomic settings. So some of you who have spoken from the audience have talked about having practices that are primarily in high-income settings. We know that if you practice in settings of real poverty, you practice in settings of homelessness, etc., you will find very different kinds of things. And I think if we were to have a research agenda, it would have to look at those issues. Secondly, Sylvia's question from the floor about EMDR was a reminder of the dramatic forms of traumatic violence that people live in, that are the settings in which we're talking about at various times. And I think the other thing that I would talk about is how people get labeled, essentially, people who have multiple symptoms get labeled essentially as crazy. And I found one of the most touching pieces of Dr. Gui's, that was on Dr. Gui's slides this morning, that finding of very, very elevated rates of hysterectomies of persons with IBS in Hong Kong, that says, which we know that if you really have multiple symptoms that become undiagnosed, that frustrates the medical systems, a lot of bad things can happen, including historically hysterectomies among women. Now, that's probably the talk I would have given. And let me just quickly go through the slides that I have and link it up with that general theme. Now, I start with this again, a notion amongst anthropologists about, if you ask about cultural difference, immediately one is in the world of cultural relativism, and this is a statement by an Oxford anthropologist who said, when issues are big enough, there is no recourse but to firmly universalistic principles, yet cross-cultural or subcultural misunderstandings on supposedly trivial issues is a very real problem at the level of close interactions between individuals, so much so that it is itself a human universal, and language looms very large in those settings. And we've already had conversations. What happened? We've already had conversations about when we're talking about cross-cultural issues, when we're talking about simply conversations between doctors and patients. And I think in particular this issue of any assumption that the more sort of sophisticated models that most people in this room have in their mind versus the ideas about bowel disease that general practitioners, in particular in rural areas, et cetera, have suggests that that's the context for this kind of misunderstanding, as well as in issues of psychopathology. I had intended to talk really about this in four frames. One, to talk about cultural differences in symptoms, one in cultural differences in psychiatric disorders, one in looking specifically at issues of personality disorders, and one in psychological processes. Let me run through those and say a few words and try to relate them to the issues that I've talked about. Symptoms, the question is from whose point of view? And there is always a question of, for instance, whether in studies of psychopathology or discussions of the kind that we've been having here, when we use an emic or an edic point of view, that is, when we which comes from the phonetics versus phonemics distinction, that is, from the point of view of a external nomenclature developed for cross-cultural purposes or for a cross-groups purposes versus one in which the internal distinctions, internal divisions that are made in language is the focus. There are also categories that we know to be experience distant versus those that are experienced near. There's biomedical categories versus local expressions, and a question of when that has to, and whether the real differences are matters of form or content. There are broad categories that can be useful, but critical local differences, and they're complex issues of translation. So this is just, if you'll just kind of read through these, this is a reminder of the real dramatic differences in the language of symptoms. This comes from an Igbo psychologist, Peter Abigbo, from eastern Nigeria. And when you look over and see these are a student normal population and a population of patients in a general psychiatric outpatient clinic, you will see that a lot of these symptoms are not only high among persons in an outpatient psychiatric setting, but also among a general population. And some of these were you in your own society, or in this setting, if somebody came and says that things like ants keep creeping in parts of my brain, people would immediately hear this as a psychotic symptom. And I would just say that symptoms of these kind, something like worms live in my body, crawling at times to different parts of my body, that when that's 1/3 of persons report yes on a symptom checklist using these kinds of symptoms, it's a reminder that it is important what kinds of issues are listed in symptom checklists that are used for identifying levels of distress that people experience. Let me say just a couple of very broad things, that in terms of psychopathology, we know that broadly the depression disorders, the anxiety disorders, the psychotic disorders, in broad terms, work across cultures. But that, on the other hand, when one looks at the various subtypes that are described, very often people do not meet criteria for the very specific subtypes. And that in some societies, if one goes to India and actually very formally uses criteria from the Psychiatric Diagnostic and Statistical Manual developed here, that NOS, not otherwise, that depression NOS or psychotic disorder NOS or eating disorder NOS turns out to be the most common subtype of the disorder, which suggests that there are local, very significant variations in subtypes. And I would say here that one of the major things that we know cross-culturally is that a mixed form of depression, anxiety, and somatic symptoms, once called neurasthenia, and not recognized formally in most, in either ICD or DSM categories, is a very, very common form of illness. And it is closely associated with chronic somatization. That, as I write there, both anxiety and depression can lead to increased bodily focus, but chronic illness, of course, also can lead to increased anxiety and depression. Of anxiety symptoms, interpretations of those symptoms begins a process that looks something like this, in which there's a perceived threat, apprehension grows, there's then bodily sensations, bodily response, which leads to an interpretation of the sensations as being potentially catastrophic, and those as then leading to increased perceived threat, and that leading to a kind of cycle that increases focus and attention. Now, this actually has very powerful cultural elements, because as you can imagine, depending on how you believe the body works, some things will be seen as far more potentially catastrophic. Certain symptoms will be perceived by some groups as catastrophic far more than others. And I just want to close by suggesting that I think there is a potential that this kind of process of cyclical production may be a useful one for also thinking about the kinds of disorders that are the focus here today. Thank you.